Hello, and welcome to Ask Dr. Dawn. The opinions expressed in this program are those of the speakers, and this is a program intended for education and entertainment. It should not be construed as a substitute for a medical consultation. We're going to start with throwing out an email. This from Anonymous in Ontario, Canada. Dear Dr. Dawn, I'm a long-time listener of your podcast. Thank you so much for all you do for listeners around the world. We all appreciate what you give to the community. I love your calm and deeply thoughtful approach. Your bedside manner comes on over the radio waves. If this is last year, after a long and challenging road with many doctor's visits due to bloody diarrhea, nausea, vomiting, weight loss, and dehydration, my 16-year-old daughter was hospitalized and ultimately diagnosed with ulcerative colitis. I'm happy to report that she is in the pink of health and her ulcerative colitis is being kept in remission due to Remicade infusions every 4 weeks. She is able to do everything a teen would want to do, so we are so grateful for this remarkable medication. Depending on the outcome of inflammatory markers, her treatment window may be pushed out to every 6 weeks. Are there any concerns about her using Remicade long-term? My own reading on this matter suggests that there is long-term data on Remicade, also known as infliximab, and sometimes it becomes less effective and the medicine has to be switched over time. Is there any concern about her being on it for years, for example? Also, is there any possibility that her ulcerative colitis could go into a full remission and she might not need medication? Thanks for your thoughts as always and wishing you all the very best in 2026. Warm regards, Anonymous. Well, let me just start by just talking a little bit about ulcerative colitis. It's one of two diseases that are not uncommon, let's put it. If you have the list of autoimmune diseases, this is one that's, up in the top 5 or 6 that we see by frequency, I would say. So what are some of the others? Rheumatoid arthritis, lupus, you get the category. It's categories where the immune system is attacking self. Ulcerative colitis is primarily inflammation and ulceration due to attacks on the wall of the bowel by the native immune system. It is a case of mistaken identity when I think we can all think about certain political things going on right now and think about how mistakes happen, misattribution, jumping to conclusions. Well, this is a case of the immune system deciding that that particular part of the bowel wall is the enemy, and in the case of the immune system, they take a take-no-prisoners approach and just annihilate the enemy. That's what the immune system does. Autoimmune diseases are triggered by something. Often there is a genetic component with ulcerative colitis. The Remicade or infliximab works by blocking the action of something called tumor necrosis factor. And tumor necrosis factor is released by certain white blood cells, and it causes tumors to die. Well, actually, it is the factor that leads to the tumor's death. If you isolate it and put it in a cell culture, it'll kill cells. So think of it as the death ray. And if you block the action of the death ray, either by blocking its receptor or blocking its ability to function, you have succeeded in turning off that particular autoinflammatory component. The problem is it's also a linchpin of the immune system in the first place. So by stopping it, you're stopping it from attacking self, but you're also stopping it from attacking non-self. And that's where some of the complications over the long term of this drug arise. For example, after about 10 years of use, there is a small increase statistically in blood cancers. And these would be things like leukemia, lymphoma. What we now know is that these types of diseases arise fairly frequently and are basically smited or smote. You'll have to help me there, grammarians, by the immune system before they even get out of the gate. So they are just knocked right out. And in the case of using a drug that interferes with that early knockdown process, they can get a foothold and begin growing. Another thing that we see is what you would expect, right? An increased risk of certain kinds of infections. Largely fungal infections, mold infections, yeast infections, tuberculosis, which in some ways has features that resemble fungi, although it is a bacterium. And other bacterial pneumonias definitely go up. Bacteria also are attacked by the tumor necrosis factor to a certain extent. So your daughter does need to be willing to become a little bit of a germphobe, a little germ shy, having a mask in her backpack and being willing to put it on in public if, somebody is obviously very sick in her presence, being really scrupulous about hand washing and hand sanitizing. And I think that's a lot more socially acceptable. And she may have to learn some comebacks to deal with teasing. And, I'm wearing this mask because you stink, to the right guy. Or, snappy comebacks are always good. Just being willing to walk away is also good. And honestly, you're sending this from Canada. I don't even know if Canadian high school kids are as mean as American high school kids. So maybe it's not even an issue. Air travel, definitely you want to mask, especially airport bathrooms, folks, please. Airport bathrooms. Okay. Now, your second question about remission. Is there any possibility that it could go into a full remission? The answer is absolutely yes, there is. And she might be able to go, and in fact, it's not unusual for this disease to go into remission. While she's in remission, she wouldn't need medication. There are tests that she could do for something in the poop. You could send this test into a lab to monitor whether she's at risk for a recurrence. Like if she wanted to travel or something like that, you could check and make sure that her calprotectin levels were in the normal range. That is a compound that's released by white blood cells when they begin the attack in the colon. And so if you see that number popping up, you know that an attack is trying to happen, trying to get rolling. Once we have someone in remission, there are a lot of functional medicine strategies to get them there. And I'm going to spend just a minute talking about that, because even now that she's on a suppressive agent, you can begin to heal and strengthen the resistance of the gut to this autoimmune disease. A few of the less complicated functional medicine strategies, because it's a whole list of things. It is, after all, holistic medicine. There's a whole list of things that we would want to do. But first of all, vitamin D. Getting the vitamin D level up to around 75 to 80 and keeping it there using supplements, preferably oral vitamin D supplements, because vitamin D has a hormone effect in the gut. Taking DHEA, which has a mild immune system calming effect in the gut, probably 25 milligrams. She's probably got plenty of DHEA in her bloodstream. It's sort of an intermediate hormone that's one of the cholesterol hormone intermediates. So you've got cortisol and testosterone and estrogen and progesterone. Those are all steroid hormones, but there's kind of interim steps that themselves have activity, and DHEA is one of them and can be taken orally. Another thing I would strongly emphasize is gluten avoidance. Not because she's gluten sensitive, and there's a long, long path between celiac disease and ulcerative colitis, but because gluten itself is pro-inflammatory. It just is. There's scientific data, an unending amount to show that it is inflammatory. And if you're trying to put out a fire, the last thing you need is to be throwing gasoline on it. So no gluten or minimal gluten, but as little as possible. Learn to love that rice and potato bread for your sandwiches. The microbiome also has an enormous influence. So making sure that she has plenty of the good probiotic anti-inflammatory bacteria. This isn't just a matter of taking probiotics. This is a matter of building an environment in the gut, getting rid of weeds, if you will, so that your garden will flourish. And that's where my next bit of advice is: get a real functional medicine doctor, someone who's certified by the Institute for Functional Medicine. They're called an IFMCP. It stands for Certified Functional Medicine Practitioner. And these doctors know how to treat ulcerative colitis such that we can withdraw the Remicade, we can rebuild the gut, we can stop the loops of inflammation and injury and subsequent inflammation. She probably has secondary food sensitivities that need to be identified and restricted, at least for the time being, until the gut is fully healed and you can successfully withdraw the drugs and the fire doesn't get started again. But I just want to end with a message of hope for you. There is absolutely every chance that she can live a normal, healthy lifespan. If she chooses to have children, all of the things that we think of that a person who doesn't have a disease can do, your daughter will be able to do. Sometimes inspiration just walks through the door, and that's exactly what happened to me this afternoon. Now, of course, respecting patient confidentiality, I'm going to read you a similar but not identical case study, and we'll pause and make some comments along the way. A 27-year-old woman with no significant past medical history presents with unsteadiness while walking and a pins and needles sensation, and also weaknesses in her lower extremities. The symptoms started about a week ago and have progressively worsened. Her vital signs are normal. Now, as doctors, one thing that crosses my mind right away is Guillain-Barré syndrome, which is a progressive paralysis and weakness in the lower extremities. But they don't usually feel it, so the pins and needles sensation doesn't quite fit. Moving on. On physical exam, she had impaired vibration sense, impaired proprioception, that's position sense, and spasticity in both lower extremities. Now, spasticity is an exaggerated reflex or jerking with rapid movement. Normally, the brain allows for smooth movement, and so when you, for example, do a knee-jerk reflex, you'll get one good coordinated kick. You won't get 3 or 4 kicks in a row, and that would be spasticity, or a kick and then a clench. Again, not normal. Pain and temperature sensation and reflexes and cranial nerve testing were preserved. She had an ataxic gait. Now, if you've ever watched someone who was drunk trying to walk, that's an ataxic gait. They can't quite keep their balance. They're sort of tipping over. She had a positive Romberg test. You may have done that in the doctor's office. They stand you up, you spread your arms, and then they tap you or push you a little bit on the shoulder. And you're supposed to not fall over, not take a step, and be able to recover your balance by twisting your torso without opening your eyes. Okay, so laboratory testing. She had a normal level of B12. She was a little anemic. Her homocysteine level was twice the upper limit of normal. Her methylmalonic acid was 3 times the upper limit of normal. But her syphilis testing was normal. Her diabetes testing was normal. She didn't have HIV. Yeah, so let's go back into the exam room and talk to the patient and say, have you been taking anything that maybe you didn't want to tell the nurse up front about? You know, reminding them that they're in a doctor's office and anything they say is private, and there are laws against me revealing it unless I think you're going to do harm to yourself urgently. And, you know, with that, she admits to, and this is, again, a case study, she admits to an average of 20 to 30 canisters of nitric oxide in the form of whippets. She's been using that many a day for about a year. She works as an exotic dancer in a local nightclub and abuses nitric oxide recreationally at work. For the past month, she's been creeping up on her consumption. And a few months ago, she had similar symptoms, and a friend suggested that she starts self-medicating by injecting herself with B12, which did seem to help. This patient has nitric oxide-induced vitamin B12 deficiency, and she's developed a demyelinating process, a myeloneuropathy in her spinal column. Nitric oxide, it's a weak anesthetic. It's a useful analgesic. It's used a lot in dental offices. It's used recreationally for many, many young adults. It's legal. It's cheap. You can get it in nightclubs, or you can get it in places that sell whipped cream canisters, because it's the gas that's used to make whipped cream. It's also used in medical freezing. It's used in science labs. And I remember stories from college. Some of the boys would go out, and the empty tanks weren't entirely empty, and they just pull a little nitric off of the almost empty tanks and have, 2 or 3 minutes of euphoria, and then come down and get all the way back to normal. But the loss of position sense and damage and weakness and spasticity are due to damage in certain parts of the spinal column. And this can present as a permanent deficit. Many people recover almost completely with large doses of injected B12, but the B12 level in the blood can be normal. How is that? Well, in this case of functional B12 deficiency, the problem is that the B12 in the bloodstream is normal as far as the blood test goes, but it's been changed. It's been modified, let's say mutated, by the nitric oxide. Now, let's get a little biochemical for a minute, because I think this is really key to understanding enzymes, or as I like to call them, molecular scissors. So molecular scissors are held together scissors themselves are held together by a little bolt in the center of the two blades, and they work to cut by pivoting on that bolt. Something similar is going on with vitamin B12. Its name is methylcobalamin, and the cobalt comes from the fact that it has a cobalt atom, an ion, that's to say an atom that is reduced. It's in a state where it can where it's accepted a hydrogen. Won't get too fancy here. What happens with the nitrous oxide is it's a strong oxidant. Like, think about it as a sort of rusting of the hinge, and it comes along and it changes the oxidation state of the cobalt ion from reduced state to an oxidized state. That completely inactivates the ability of the methylcobalamin to act as the linchpin or the hinge pin in the scissors. So those scissors will never cut again unless that reduction state is restored, and that's very hard to do. So it's a functional deficiency, and where you're going to find blood tests is downstream, where the scissors don't cut. You're going to see a buildup of things that should have been cut by those scissors. And so that's where the elevated homocysteine and the elevated methylmalonic acid show up. And why do we care about this? Well, you may have heard of SAMe, S-adenosylmethionine, right? And if you can't convert homocysteine to methionine because your molecular scissors are broken, you won't be able to make myelin sheaths on the nerves.
what's multiple sclerosis? Well, that's a disease where the immune system attacks those myelin sheaths and breaks them up. So in this case, they're not forming, they're not being maintained, and they're eroding. They're basically like getting moth-eaten, and that affects the transmission of the nerve signal such that people can't feel their feet. In the case of my patient, she went to the emergency room because she suddenly couldn't feel her feet and she couldn't walk right, and she was found to have this condition. Her doctors did recognize it, and they properly treated it, and she's had partial recovery. But the treatment is high-dose daily injections of B12, and that has to go on for months. The recovery curve on this is up to 84 weeks after treatment is begun, so as little as a month and as much as many years. And this is not something to mess with. It's a good example of a substance which, when used now and then, is harmless. Makes me kind of think about coca leaves or pot. You know, it's like, oh, it's a traditional herbal that's been used by primitive peoples, you know, native peoples, chew the coca leaves and it gives them a little boost. Then somebody says, well, let's, see if we can get a bigger boost by making a powder, and let's put the powder in the nose, and wow, that's a boost. And then somebody else says, well, yeah, but can I make it, can I stretch it? Can I make it go further if I smoke it? And I have to change it molecularly to smoke it. And then once I do that, we end up with something which is pretty addictive. And, well, that's the story of coca leaves to crack, right? And then, of course, you have pot itself. We've watched that one go from, you've got this pot that's got some THC in it. You have to smoke it. That smoking kind of limits it. Then we get the vapes, which allow you to smoke more because you're not irritating your lungs as much, so you can take more in. And, of course, your body learns how to process it, and so then you need more. And then somebody comes up with an oil extract, and before we know it, we've taken a benign herbal, intoxicant, let's call it, and we've turned it into something that's causing dangerous withdrawal symptoms when you stop using it. Cannabis discontinuation syndrome. Crazy, right? But humans just can't help pushing it, and nitric oxide is another example. This can have really severe consequences. It just shouldn't be something that you use every day. And taking vitamin B12 orally to sort of protect yourself against it's probably not going to work. And even without daily use, nitric oxide doesn't really play well with others. Let's talk about nitric oxide and Viagra, and its friends, Levitra and Cialis. So those are phosphodiesterase inhibitors, another kind of molecular scissors, phosphodiesterase getting inhibited by a drug. This should start to emerge as a theme. And in this case, if you mix nitric oxide with that, you're going to cause a dangerous drop in the blood pressure. In fact, you could induce a heart attack. If you're using methotrexate, which is used for cancer and some rheumatic diseases, it drastically increases the toxicity of that agent. Something to keep in mind, by the way, if you take that drug and the dentist suggests nitric oxide, you want to say no. But it's really on you to know that you're taking nitric oxide. Your dentist could make a mistake. Your job is to help them from doing that. Cocaine, amphetamines, MDMA, probably, as far as that goes, Ritalin and Adderall are going to put excessive pressure on the cardiovascular system, increase the heart rate, raise the blood pressure, and then, of course, you're going to be jumping around if you're doing MDMA and getting dehydrated. So you're asking for a cardiovascular event. And yes, young people in their 20s can have heart attacks. Ketamine, LSD, other hallucinogens, well, it's going to really increase the possibility of what the quote-unquote bad trip. And it's going to increase the likelihood of that, and it's going to increase the severity and the duration of that. So why are we combining these things? Alcohol, benzos, and opioids, you're looking at a faint. You're looking at severe respiratory depression, passing out, maybe aspirating your vomit. Again, no, not a good idea. And while we're on combinations of drugs, most people know not to mix alcohol and opioids because they both depress the heart rate and the breathing. And opioids actually suppress air hunger, which means if you drink to the point of passing out and you've got some Vicodin on board, the Vicodin may prevent your brain from stimulating you when you're not breathing, because that mechanism that is in fact why people with sleep apnea are sleep deprived. It's the brain going, wait a minute, I'm starving of oxygen, wake up. Well, that doesn't happen with opioids. They block that life-saving air hunger. And, well, off we are. Mixing a stimulant and a depressant. So there's something like called a speedball, which is cocaine and heroin, or any other combination of opiate and stimulant. This really increases the body's need for oxygen. So you need to be taking deep breaths and breathing fast, but the depressant slows down the breathing rate, and this can lead to fatal respiratory depression. By the way, the old myth about mixing different types of alcohol will get you drunker, no, it just means you're drinking alcohol. It's all ethanol. The concentrations are different, but that's about it. However, what is true is that darker colored alcoholic drinks, red wine, brandy, are going to have more extra stuff along for the ride that may require some breakdown. And if you have any difficulties with detoxification or you're dehydrated, it may give you more of a hangover than white wine or vodka. So that myth probably is true. Saw this story in Le Monde, French magazine. It's actually coming out of Canada, but Canadian researchers have developed a teeny-weeny, itty-bitty 3D printer to repair vocal cords. Vocal cords are these little membranes, if you will, these little flaps of skin that are surrounded by muscles and are tightened. Those muscles tighten and loosen them. And right now, all of those little muscles around my vocal cords are dancing the cha-cha in order to produce the sound that later on the muscles of my mouth, tongue, and lips and teeth are turning into what you're hearing. Speech is an amazing thing, but they're very delicate, those vocal cords, and they can be damaged by yelling and screaming and by the insertion of breathing tubes. And when they're damaged, they may develop polyps, which gives people that really hoarse kind of Lou Reed sound, which if you're going for it is fine, but but that vocal burr definitely can get in the way of being comprehensible in your speech. And so vocal cord therapy is done to remove that. But the problem is you shave off that bump, that nodule, and it grows back because it's like a keloid. It doesn't grow flat and just seal up. You can't get in there and stitch it. But researchers have been able to miniaturize a sort of 3D printer, and they're able to visualize the lesion after the surgery, remove the nodule, do the insertion of the device, and actually print hydrogel in a small tube along the wound and flatten it out just like you would spackle repairing a wall, so that you have a perfect bandage, if you will, or lid under which the healing fibroblasts will grow and reconstruct skin, but they aren't going to be able to grow up into that bump. So pretty amazing little thing, but going in with a small device and doing 3D printing. If you never saw the movie Fantastic Voyage, I highly recommend you take a look, because that in that film, people are shrunk down to this quite small, about 20 microns, and they get into a little submarine. Yes, a little submarine. And they go into the body and migrate from a vein across the heart, dodging the heart valves, and then up into the brain, where they use a laser beam to destroy a brain tumor in a very, very important oligarch. I mean, some guy who's politically very important. Anyway, the necessity of that is unquestioned in the plot. But now that I think about it, that was a lot of resources to spend on one person. Anyway, speaking of lots of resources, let's talk about a new drug coming to your pharmacy soon. The quest for a drug that it's the new cholesterol, right? Because we have drugs for cholesterol. We have this other thing that is a lipoprotein that is pronounced Lp(a). It's written capital L, lowercase p, parentheses A, and then this is a risk factor for heart disease. It was discovered back in the 60s. And just like plaque, it tends to adhere to the arterial wall, but it carries a second protein that gets attached to it when it's made in the liver. And this second protein is a procoagulant. So it causes blood clots. And that is a problem because it is genetic, or almost entirely genetic. And many people don't know that they have it because it's not part of standard cholesterol testing, because we don't have a drug for it. You can't fix it with diet and exercise. Many cardiologists say they routinely hear that primary care doctors don't see the point of testing because, hey, there's no drug for it. Why am I going to waste my time explaining to the person that they've got something I can't treat? That's a fair question. But it's pretty common. In a study published recently, global study, so across many ethnic groups and regions, they looked at 50,000 people, and about 14% had been screened. So we've got a ways to go with that. What's the prevalence in the population? Enough to matter. The trial is for one of several drugs. This one's called pelacarsen, and it does reduce LPA levels up to 80%. It's given in an injection. And coming up soon, the drug company will be able to reveal whether lowering LP levels also reduces events from patients who have heart disease. See, the holy grail here is not lowering cholesterol, right? It's lowering heart attacks or lowering strokes. So there are other drugs that do the same thing, different drug companies. So this one is Novartis, Amgen's got one, Eli Lilly's got one. The gang's all here, folks. If you want to get a test for LPA, and after you hear the next bit of the story, you very well might, it costs about $50 if you want to buy it. Your doctor can order it for you under your insurance, and it usually will be covered. So it's just what. And so the question is that I would ask is, why wait when we already have something that will work for this? Let's go back to a guy named Arthur Ashe, who was a very famous tennis player. In 1983, he received a blood transfusion, which was contaminated by HIV, and so he was diagnosed with AIDS about 5 years later. Again, this is in the 80s. We have no testing. We have no drugs. And I think actually the first drug probably came out in about 1988. And AZT. In 1992, there was a seminar where they talked about Arthur Ashe's coagulopathy because he had a very high LPA. And this has nothing to do with his HIV, but it is a congenital defect. It blocks, as I said, it's a procoagulant. It blocks the fibrinolysis. In other words, when there's an injury, what's supposed to happen is that you make a fibrin plug, and then that plug is broken as soon as the blood stops bleeding and you've got a decent clot. The body starts breaking down that plug. And it's a dynamic process. If the plug hangs around too long, then it can gather platelets and debris and trigger a blood clot completely across the blood vessel. So it's a very kind of plumbing-like image, too much stuff getting stuck in the drain and the water backs up. There are Chinese herbs that have been around for, well, herbs have been around for longer than humans, as just by definition, but it has been used in Chinese medicine for a very long time. And it's something like, great dragon formula, but it's ground up worms. And this therapeutic agent is called lumbrokinase because it is broken. It's basically broken up worm bodies. Back to Tim again with the worm. And a lumbrokinase is something that blocks the anticoagulant aspect of LPA and puts it back into balance. So there have been studies that show that if you have a high LPA value, we know you have a higher risk of heart disease. And there have been studies looking at using lumbrokinase in people, and it actually lowers the LPA value. It's a drug that's already here. It's a special kind of worm, so don't go digging in the yard because you need basically a particular worm and a particular preparation process. But lumbrokinase is available on the open market. It's a product called Boluoke, Boluoke, and it's available from medical suppliers. The dose is on the package. I don't have it here. But if you know that you have LPA, and I have at least one patient that I'm going to send this article to because she and I struggled trying to reduce her LPA some time ago, and the only thing known to do that is very high doses of niacin, which is a terrible drug to take in high doses. It causes essentially menopausal hot flash type symptoms and diarrhea. So not well enough tolerated for general use. But the lumbrokinase has a pretty good track record, and so something to think about, getting checked for LPA, particularly if there's a family history of heart attacks in young people. That's one of those flags that does make a cardiologist think of checking for this if they get that in a family history. But maybe not all primary care doctors necessarily know to do that. My job is to both get the public thinking about it, but also get the doctors thinking about it. I think I'm going to jump to a short one. Choline, right? Researchers have found that people with anxiety disorders consistently show lower choline levels in key brain regions that regulate thinking and emotions. Scientists believe nutrition could play a role in restoring balance. Many Americans already fall short of the recommended choline intake. This study showed that choline is 8% lower in people with anxiety levels. They looked at the neurometabolite levels in people, and they found that the ones who had higher breakdown products of adrenaline or epinephrine were the ones who tended to have, that was a marker for anxiety, which makes sense, but also in those individuals they found lower levels of choline. And choline is found in lots of foods, so I'm going to give those to you in a minute, but lecithin, eggs, lecithin, beef, chicken, fish. No, don't worry, vegetarians, soybeans and milk. Organ meats are really great sources. Some forms of omega-3, salmon actually has a lot of choline in it. You need 500 milligrams a day. 2 eggs gives you 300 milligrams if you eat the yolk. You can also just buy lecithin and add it to your smoothie. If you tend towards anxiety, my suggestion is maybe this is you, and maybe you'll benefit. And what have you got to lose?
Well, that's about all for this week's podcast. Please go to AskDrDawn.com for news about our future plans. For now, this is Dr. Dawn saying so long and stay healthy.
Ask Dr. Dawn is brought to you by Jiva Media. Production and editing by Charles Bansky. Music by John Scoville.